think let's move on and let's hear Dr. Andy. We all know he was introduced during inauguration and the principal guest lectures, and he will talk to us about retinal necrosis.
Thank you, Dr. Varma. Again, it's a pleasure and an honor to be here as your keynote speaker. I'll point out, do I have a pointer here? Maybe not. That this is a rendering of the new eye hospital that we're building in Pittsburgh, $350 million Vision Institute, which will be very exciting when we move in about a year. I've been fascinated by the topic of necrotizing retinitis since I was a resident, and I saw my first patient with, at that time we called BARN, bilateral acute retinal necrosis, for which we had absolutely no idea what caused it. We didn't know if it was a virus or not, and we had no treatment. And I watched a young woman with a couple of children in her 30s go totally no light perception as we just watched in bewilderment as to what was going on. Anyway, if you look at the various conditions that can cause necrotizing retinitis, it's really extensive. You know, we always think of the VZV and HSV as our typical ARN, but there's a lot of things that can look just like it. So we can't just immediately assume a patient has ARN when they present to us. So for example, toxoplasmosis is the most common cause of necrotizing retinitis in America. And when I was in training, we were taught that 97% of cases of necrotizing retinitis from toxo was from recurrence of a congenital lesion. And we would see a pigmented chorioretinal scar with active retinitis on the edge of it, or chorioretinitis on the edge of it. But now that we have so many patients who are immunocompromised for various reasons, whether it's HIV or chemotherapy, whatever, we're seeing more and more primary toxo. This patient, a young man, presented to the emergency room. I was absolutely convinced it was ARN. I did PCR, expecting it to be positive for VZV or HSV. But my residents, unknown to me, also ordered a test for syphilis, and that's the one that turned out to be positive. So even syphilis can look like anything. And here's a patient with lymphoma, infiltrate, looking very much like a necrotizing retinitis, and of course a purchase type of retinopathy. And here are two cases of HSV2 where it looks more like a retinal vasculitis with very little necrotizing retinitis. And so we have to be suspicious of ARN in patients that do not absolutely have the characteristic necrotizing retinitis. And in one of my patients, the PCR was negative, and the trick here was to stick with your guns and repeat it in a couple of days. And here's a more classic acute retinal necrosis that we would recognize from, in this case, VZV. And here's another patient who had VZV that have been treated and the retina detached, and you can see that this is under silicone oil with a buckling effect in the periphery, and we're able to save his vision. Here's a patient that came in with EBV, and this was post-op. You can see the buckle under oil with the necrotizing retinitis, and I thought for sure this was just simply ARN. The PCR turned out to be positive for EBV, but what was interesting is when we did the surgery, the nurse anesthetist pointed out that the tongue was white, which made me think, well, maybe this was Candida. And we called the infectious disease specialist, and he said, no, this is hairy leukoplakia, and it's absolutely classic for EBV. So we're always learning. So we know a lot about acute retinal necrosis. It's a pan-uveitis. The incidence is somewhat rare, 0.5 to 0.6 new cases per million. The visual outcomes are often poor. 25 to 75% of eyes have vision worse than 2200. Retinal detachment rates average around 50%. VZV is more common. EBV is rare. Patients are usually immunocompetent, although the VZV patients tend to be older and perhaps have immunosenescence, as I discussed yesterday, that we're all acquiring. And some studies suggest the outcomes for VZV and HSV, and as well as the treatments, are very similar, and this is, I will disagree and show you why. So VZV tends to be in an older age group. They may have a history of shingles. HSV 1 and 2 tend to be in a younger age group, and they often have a history of neonatal herpes. They both present with acute uveitis, redness, pain, conjunctival injection, KP, AC reaction, endovitritis, and often a retinal vasculitis with the classic necrotizing retinitis. The clinical pearl here, and in America where we worry about lawsuits and malpractice, anytime a patient presents with iritis, anterior uveitis, you must dilate them and you must look for necrotizing retinitis or sarcoidosis or any other posterior fundus condition that can also present with an anterior uveitis. And in fact, most of the lawsuits regarding ARN are due to delayed diagnosis because the eye was not dilated. The diagnosis is based on history and clinical exam, and we're very fortunate in our institution. We run PCR for VZV, HSV, CMV, and toxo on a daily basis. And again, if the PCR is negative, but your clinical suspicion is still very high, you can always repeat the test. So before we even get the results of the PCR back, I think this is one of our true ophthalmic emergencies that ARN can progress somewhat quickly. PORN, it seems to progress minute by minute, but ARN is probably more like 12 hours by 12 hours. But if I'm very suspicious, I will treat with an intravitreal injection of foscarnet most commonly, and I will begin IV acyclovir. Now, it's been shown that oral valacyclovir is equivalent to IV acyclovir for treatment, but I like to bring the patient in the hospital because I think I get better compliance. Sometimes patients have difficulty getting valacyclovir. So we did a study, and we wanted to look at our patients who had positive PCR ARN, and it was a retrospective series, and we collected a lot of data, and so all the patients were treated with 10 days of IV acyclovir, and then they were switched to valcyclovir for a minimum of 3 months to reduce recurrence or spread to the fellow eye. And I use foscarnet because I don't have to dilute it. I can take it right out of the IV bottle for intravitreal use, and I give an injection every 48 to 72 hours for 3 or 4 injections until I see improvement. 2 of the eyes received intravenous cidofovir because of my experience, and I'll show you the data, that HSV is a worse candidate for ARN, and I think cidofovir, in my experience, works better, although it has its own risks, such as renal failure and rarely uveitis. You can see that we had about 8 cases of VZV and 12 of HSV. You can see the age range, that the HSV are definitely younger patients, where VZV tend to be older patients. And looking at the retinal detachment rate, you can see that out of the 8 patients, 75% of them with the HSV2 had detachments. And of those, 50% went to no light perception. So very, very telling in my experience that HSV2 is a much worse disease than ARN, which of the ARN category, and therefore that's why I've now been considering first step of cidofovir if it's possible. And you can see the visual outcomes. So in conclusion, the mean age for HSV2 was much younger than that of VZV. HSV2 ARN had a higher rate of retinal detachment despite similar treatment protocols. The final visual acuity was worse in the HSV2 group when compared to VZV. And in cases of intractable ARN, cidofovir may be a consideration in spite of its known complications and toxicities.